Testicular lesions are relatively uncommon in the adult male patient, but the intratesticular lesion always presents a problem. Most often in the adult patient, the intratesticular lesions are malignant. Up to 95% of lesions are malignant, the rest are benign. Of the malignant lesions, most of these are germ cell tumours. Germ cell tumours may be of different histological type. They develop from either a unipotential or a totipotential cell and divide into either seminoma or non-seminoma tumours. There are a number of lesions that are benign that mimic these malignant lesions, and it is very important to be able to clearly identify those lesions which are malignant from those which are benign. A malignant lesion means the patient will lose that testicle, and it clearly is of importance to the patient not to lose his testicle if that lesion is benign. On ultrasound, these lesions may take many forms. The classical seminoma is known to all of you as that low reflective, well circumscribed abnormality within the testes. A teratoma, which contains many different cell types, will look very different with areas of calcification and mixed echogenicity. However, these germ cells all require an orchidectomy. If there is a segmental infarction or an epidermoid cyst, both of which are benign lesions and may mimic an intratesticular malignant abnormality, any pre-operative assessment that indicates that the lesion is benign will take importance to allow preservation of the testes. There are a number of lesions within the testes which cannot be characterized fully on the B-mode ultrasound examination. This slide shows you a number of lesions which were not clearly identified prior to operation. These patients had their testes taken out, but these lesions were all benign. A recent publication out of Italy demonstrates that a large number of lesions found incidentally on the ultrasound examination, and this was in patients with infertility being investigated for that abnormality. 80% of these incidental lesions were actually benign. This is where adding contrast-enhanced ultrasound to the examination of the testicular mass will help to determine whether or not this is a malignant or a benign abnormality. Adding color Doppler ultrasound to the investigation of a focal testicular abnormality may be helpful. This landmark paper, published in 1992, indicated that the use of color Doppler ultrasound in a cohort of 28 patients was useful only if the tumor was greater than 1.6 centimeters in diameter. Any increase in vascularity indicated that the abnormality was malignant. The authors concluded that a color Doppler ultrasound was not useful for those tumors less than 1.6 centimeters, but now, with the advent of better technology, we know we can ascertain color Doppler flow in the very small lesions. An indication of malignancy is therefore the presence of hypervascularity. A benign lesion should demonstrate no increase in vascularity. This is the hallmark of investigation of the focal testicular lesion with an ultrasound examination. If we can add contrast-enhanced ultrasound to this pathway, bearing in mind that contrast-enhanced ultrasound exquisitely demonstrates the vascularity of the lesion, we should perhaps be able to ascertain whether or not a lesion is malignant or benign, entirely based on the vascularity. Contrast-enhanced ultrasound is not the only new technique available for investigation of focal testicular lesions. Elastography has also been demonstrated to be useful in ascertaining the hardness of the lesion, and with the hardness of the lesion indicating the presence of malignancy. A combination of these two techniques may in the future be much more advantageous in investigating the testicular abnormality. Now let's go back to contrast-enhanced ultrasound, the focus of this lecture. Those of you who are not familiar with contrast-enhanced ultrasound will not fully appreciate how safe this agent is. This large study out of Italy, where SONOVIEW is used predominantly to investigate liver lesions, renal lesions, and lesions elsewhere in organs in Europe, has demonstrated that there are very, very few adverse effects. In 0.0086% of investigations, there was mild symptoms such as itching, nausea, sense of warmth, dizziness, headache, and mild hypertension. Very few serious adverse events occurred, and these were all suitably treated. No one died out of all these patients. So using contrast-enhanced ultrasound is safe. However, in Europe and in the Far East, but not yet in the United States of America, this contrast agent is only licensed for use in a limited number of areas. It is licensed to be used in the liver, the heart, the breast, and for vascular areas. Therefore, any application outside these areas are off license. Notwithstanding this, the European Federation of Societies in Ultrasound and Medicine and Biology have issued guidelines and recommendations on non-hepatic applications. Every single one of these non-hepatic applications are off license, but the accompanying editorial indicates the reasons that this is acceptable. First of all, contrast-enhanced ultrasound has a number of distinct advantages over CT and MRI, and this is particularly true in investigating lesions of the scrotal sac. Ultrasound remains the best modality for looking at superficial structures. With its better resolution, you're able to actually distinguish very small abnormalities in the testes. So contrast-enhanced ultrasound of the testes is very useful. Contrast-enhanced ultrasound can be performed immediately. You don't need any preliminary laboratory testing. You don't have to have patients who have renal problems turned away from the examination. And you can carry it out anywhere. You don't have to carry out the examination out within the radiology department. You can take the machine to the patient. It operates in real time. You can ascertain rapid changes and capture these and review these on your cine loops. All of these off-label uses are unlikely ever to become licensed. This is not a problem for the clinician. This is a commercial problem. But if you're going to use contrast outside the labeled indications, you are allowed to do it by many medical regulatory authorities. And I talk now about the General Medical Council in the United Kingdom, where I practice, because you can use a drug off license under the following circumstances. Be satisfied that it would better serve the patient's needs. Be satisfied that there is sufficient evidence base, experience of using this agent to demonstrate its safety and efficacy. And you take responsibility for prescribing this medicine. If I could indicate to you that over 70% of drugs prescribed for children are not licensed, you will understand how many clinicians throughout the world take responsibility for administering safe medicines to people who need them. There should be no restriction on you using contrast-enhanced ultrasound where you think it's going to be useful and beneficial to the patient. Now let's go back to look at contrast-enhanced ultrasound of scrotal diseases. I've already said that ultrasonography is the imaging modality of choice for examination of the scrotum. It is unrivaled in this area, and most operative procedures are based entirely upon the ultrasound findings. But occasionally these findings may be difficult to interpret, and any misinterpretation has the possibility that that patient may lose the testicle. This is a particular conundrum when there is perhaps poor differentiation between the very hypovascular and avascular lesion, where if you think that there is no vascularity in that lesion, that it's benign disease, it may be a poorly vascularized malignant lesion. And this remains a conundrum even with the use of color Doppler ultrasound. Adding contrast enhanced ultrasound may just tip the balance to indicate that there is vascularity present. Colour Doppler ultrasound is very observer dependent, and you may not be confident of the interpretation from your examination.